The recording will be posted on the committee's webpage after the meeting. For everyone's reference, today's agenda can be found under the first tab in the meeting materials. As a reminder for everyone, please remember to use the Primary Care Committee email inbox to send updates or questions. And if you are not a member of the committee, please turn your camera off. Now I will turn it over to our committee chair, Dr. Judy Zerzenthal, to call the meeting to order.
Great, thank you, and welcome committee members. It is now 2:04 p.m. and I call the May 30th meeting of the Advisory Committee on Primary Care to order. Thank you all for joining us today. So I'm going to start with an overview of the agenda. We, as usual, are going to do roll call and then vote to approve the meeting summary of the April committee meeting. We'll open the floor for public comment. After that, we'll hear from Alina Sawyer from HCA on policy recommendation number 1, increasing primary care expenditures by 1% annually. Next, we'll hear from Hannah Hartman, also from HCA, on policy recommendation number 2, increase Medicaid reimbursement for primary care. And then we're going to take a deep dive and a thorough overview into policy recommendation number 6, which is incentivizing and measuring non-fee-for-service payment methods. Karen Johnson, who's the Vice President for Practice Advancement from the American Academy of Family Physicians, is gonna start with that and give us a look at what other states are doing. And then after Karen's presentation, we'll hear from Hannah again to give us more of our state level look at what's being done and sort of finish off recommendation number 6. After that, I'm going to give you a quick update about the plan for the meeting schedule for the year and what to expect moving forward. And finally, we're going to hear from Gretchen Morley from the Center for Evidence-Based Policy, who's going to help walk us through what to expect for our June meeting, how we're going to narrow this list of 7 recommendations to top 2 or 3 priorities and recommendations to the cost board. We have time built in after each presentation for questions and discussion. And after all of that, we'll adjourn. So let's do roll call. I will call on members by first name in the order listed on the agenda, which is alphabetical order by last name. When I call on you, please unmute your microphone and let us know you're here, and then go on mute again. So Crystal?
Here.
Thanks. Sharon Brown?
Here.
Hello. Tony?
Here, thanks.
Great. Michelle?
Hi, here.
Hello. Tracy?
Here. Hello.
Hi. David?
Hello, I'm here.
Excellent. DC?
Hi, DC here, thanks.
Hello. Sharon Eloranta?
I'm here. Hello.
Hello. Greg? Chandra? Meg? Cheryl?
Yeah, hi everyone, I'm here.
Excellent, thanks. Lon?
Hello, I'm here.
Hi. Katina? Mandy? Jonathan?
Here.
Great. Sarah?
Sorry, this is Katina. I'm here.
Oh, excellent. Thank you. Sarah? Linda?
Hey, this is Maddie Wiley for Linda. Because of a work
yes.
conflict, she had resigned and was supposed to be being replaced by Shannon Fitzgerald, I think, but I don't know where that's at.
You are right. We will take a note of that and fix it for next time. Yes.
Okay, sure.
Thank you. Sean?
Present.
Excellent. Stacy?
Hi, I'm here.
Hello, Ginny? And Maddie. Hello
I
again.
am here.
Excellent. So thank you all. I'm going to turn it back over to Rochelle, who will facilitate review of the meeting summary.
Thank you, Judy. If you can all please join me in turning to the April meeting summary in the meeting materials. And just a quick reminder, the recording of last meeting is posted on our webpage. Is there any discussion of the meeting summary or proposed changes? And if not, would someone like to make a motion to accept the summary? Will someone make a motion to accept the April meeting summary?
I
I
was
move
gonna
to
say I move
accept.
approval.
I'll second it then.
Thank you. All in favor, say aye.
Aye.
I,
Aye.
Aye.
Any opposed? Okay, great. So it looks like the April meeting summary is approved. Next, we're going to open the floor to public comment. If a member of the public wishes to provide public comment at this time, please raise your hand. When you are called upon, please state your name and affiliation, if any, before speaking. Please do not raise your hand more than once. This helps to ensure that everyone has a chance to speak. You are also welcome to provide comments in writing via email at any time. Please remember that this is the time for public comments, and any question and answer sessions during the meetings are time for the committee members to ask questions only. So let me check to see if we have any comments. Okay, it looks like we have one. I'm going to go ahead and
Hi, can you hear me? This is Ginny. I'm actually a member of the committee, but I didn't know how else to indicate that, so I just raised my hand in this process to be promoted.
Oh, okay. Thank you for doing that.
I'm sorry to be a couple of minutes late.
No worries. Thank you for letting us know you're here. Sorry, can one of my associates help promote you for some reason? Oh, okay. It looks. Did that work? Were you promoted?
Yes, I am. Thank you.
Perfect. Thank you. I was having an issue with my mouse there. I couldn't click the button. Okay. Just checking public comment again to see if we have any hands raised. I don't see any. I'll just give it one more minute. Do a quick scan, see if I'm missing anyone. Okay, it doesn't look like we have any public comments. I'm going to go ahead and turn it back over to you, Judy.
Great, thanks. So first I want to welcome Alina Sawyer, who's a management analyst here at HCA, to present on increasing primary care expenditures by 1 percentage point annually. Recommendation number 1. So take it away.
Actually,
Oh, is Kaylee gonna do it?
I'm gonna kick us off today. Yeah. So I'm Kaylee Dufresne. I'm the special assistant to the chief policy officer here at the Healthcare Authority. And we had a late change in our agenda today. Hannah Hartman is unfortunately had to be out this afternoon. So apologies, we're going to be a little bit on the fly and a little bit rough, but I think we'll power forward as always. So hopefully you can all see my screen. Rochelle or someone, can you give me a thumbs up if you can see this okay? Yes,
can see
maybe.
it. Yes.
Okay, great,
Thank
thank you. All right. So just want to take one brief step back to remind this group why we're here, make sure we're on the same page about what we're talking about today. So we're really here to talk about chronic underinvestments in the primary care system. That, you know, as we've discussed multiple times with this group, both nationwide and in Washington, we see challenges for our primary care infrastructure. That so much so that the legislature back in 2022 set a target for Washington to reach this 12% expenditure goal, that 12% of all of our expenditures would be dedicated to primary care spend to really support healthy, robust healthcare system. So in that vein, this group was formed to help support the primary care advisory, this group, the Primary Care Advisory Committee, was formed to help support the Healthcare Cost Transparency Board in its goal to bring not only transparency to our spending in the state, but to really help make it more affordable for consumers. But knowing that a key piece of that is this primary care infrastructure that is so necessary to health and well-being in the state. So this group has accomplished a huge feat in taking the first step of that goal to reach 12% by defining what's included in that primary care expenditure target that we're trying to get to. So you all spent a few months talking about what are both the claims-based, the fee-for-service components that we should be including as primary care spending, and you landed on a definition that combines a place of service, practitioner type, as well as service code. So the mix of those three things together comprises that claims-based component. And then you also agreed that there should be what we're calling a non-claims-based component, which reflects some alternative payment mechanisms to pay for services like capitation or salary expenditures, payments for some non-billable activities like care coordination that happen in the primary care setting. Perhaps some infrastructure investments like health IT, workforce, and then the incentives for primary care providers for quality performance or other arrangements. So that is the great work that you all have accomplished. And just a reminder that you are tasked with this huge goal of reaching that 12% of all healthcare expenditures are dedicated to that primary care definition that you've agreed upon. So just a reminder, there are some levers that you have to play with to reach that 12%. So this ratio is the total primary care spend divided by total spend. And to get even more annoyingly at basics, spending is price times utilization. So the levers that you have to play with are built into those equations. You can play with price, you can play with trying to incentivize utilization to go up. And the way that you're going to have to do this might impact both that numerator and that denominator. And we have to be conscious of how you go about doing that to raise that top number by the right amount, and either to keep the denominator the same or to decrease it over time. So just keeping ourselves grounded in the reality of this math and the challenge that we face to try to get to some strategies that achieve increasing this ratio over time. So here are those 7 strategies that we've been talking about the last few months to try to get to that 12% spend ratio. Last month, I think you talked about patient engagement efforts and how you can use shared decision-making to try to encourage patients to participate in primary care and really be engaged in that care setting. I think you also talked about number 7, how you can use this primary care ratio perhaps in a way that's a little more targeted and easy to manage with a per member per month or per capita type of expenditure rather than that tricky ratio dynamic that I just talked about. I know you've also heard in the past about from our Department of Health colleagues about a variety of workforce initiatives that are going on. And truly all of these components we know play a key part in shoring up this primary care infrastructure in the state. Like Judy mentioned, the three strategies that we're going to hit on today are the ones in these green boxes. And we'll have time after each of our brief presentations to talk about them, to talk about the nuances of these and how they might play together. First up is going to be Elena to talk about really setting a tangible target for us to work towards of how much we want to see of an increase year over year. I'm going to talk about one of the, probably simplest, most straightforward strategies that we have of increasing Medicaid reimbursement. And then we'll hear this great presentation from Karen Johnson and a complimentary presentation from me again about alternate payment models in these arrangements. So I'm going to pass it over. Thank you all for bearing with me through that level setting. And I'm going to pass it to Elena Sawyer about the 1 percentage point target increase.
Awesome. Thank you so much, Kaylee. Can everybody hear me all right?
Yes.
Awesome. Thank you. So, hi, everyone. As Kaylee said, my name is Elena Sawyer. I'm a Senior Health Policy Analyst at HCA, and I'll be talking about this first strategy towards reaching that 12% primary care expenditure goal, which is increasing primary care expenditures by 1 percentage point annually. We looked at strategies from a few different states, and I'll talk through what those states did, whether we can know if it influenced the primary care expenditure ratio, and whether it would work in Washington. If you have any questions while I'm talking, feel free to raise your hand or write them in the chat. Otherwise, I'll pause at the end of this section for us to have a bit of discussion. So first, I'll talk about Rhode Island. Rhode Island's Office of the Health Insurance Commissioner, or OHIC, required carriers to increase primary care payments by 1% per year from 2010 to 2014. The state's approach was to increase primary care investment, or that numerator that Keely talked about in a previous slide, and to curb growth of overall spend via a hospital spend cap and overall system cost benchmark target, so keeping the denominator the same. One reason that Rhode Island was well positioned to do this is because the OHIC has oversight over negotiated rates between insurers and hospitals, as well as the individual small group, fully insured, and large group markets. In thinking about whether this influenced the primary care expenditure ratio in Rhode Island, the answer is yes. So the dual effort of primary care investment and OHIC's requirement that insurers limit the average price increases for hospital services both increases the numerator and stabilizes the denominator. That said, this wouldn't necessarily work in Washington. The Washington OIC does not have authority over hospital rate negotiations with insurers, and without that rate review authority or broader payment reform, it will be impossible to increase the primary care ratio in the same manner as Rhode Island. That said, it was still helpful to look at Rhode Island as an example and think through how the state was able to influence their primary care spending. I'm seeing Ginny's question in the chat. I don't know this answer off of the top of my head, and if someone else does, I definitely invite them to unmute and share it. Otherwise, I'm happy to follow up afterwards. Awesome. Then I'm going to keep chugging along. Kaylee, I think I'm ready for the next slide. Next, I'll talk about California. So in 2022, California formed the Office of Healthcare Affordability, or OHCA, and they proposed 2 primary care investment benchmarks. The first is a relative improvement benchmark, which asks each payer to increase primary care spending as a percent of their overall spend by 0.5 to 1% per year through 2034. And one is a statewide absolute benchmark of 15% of having that be primary care's percentage of total medical expenses, also by 2034. It's a little bit too early to know whether this would influence the ratio. The formation of the OHCA emphasizes California's commitment to lowering healthcare costs, but it's too soon to say whether these primary care benchmarks will have any impact. OHCA does not have the authority to enforce the benchmarks, so there aren't any financial teeth to the policy right now, but it does have the authority for payer data collection and public reporting, which does provide some additional accountability to the payers. When thinking about whether this would work in Washington, the answer is that it definitely could. While California's recommendations are new, they may be able to serve as a guide or inform Washington's recommendations moving forward. All right, Kaylee, ready for the next slide? Now I'll talk about Oregon's monitoring and performance improvement requirements. So Oregon passed legislation requiring carriers to report on primary care's share of overall health spending and to achieve a 12% primary care spend target by 2023. Additionally, commercial carriers that do not meet the 12% target are required to submit plans to the Oregon Health Authority and Department of Consumer and Business Services of how they're going to go about increasing primary care spending by 1 percentage point each year. It's also unclear whether this influenced the ratio. Data are not yet available for 2023, so we can't say yet what the impact has been, but ideally requiring carriers to submit plans for shifting the expenditure ratio annually may provide ongoing accountability. In terms of whether this would work in Washington, likely yes, although it is a little bit unclear whether it would influence that ratio. That said, asking carriers to submit plans for shifting expenditure ratio will provide or may be beneficial for ongoing accountability and incremental change. Well, we move to the next slide. I'm just seeing there's a couple questions in the chat or, oh great, just some context on Rhode Island. Thanks so much. I could quickly go through these recommendations and then we can move into that additional discussion if that works for everyone else. We chose to bucket our recommendations into kind of two pieces. One is recommendations for this group to make to the cost board, and the second is recommendations of other next steps for HCA. So for our cost board recommendations, the cost board could recommend that the legislature codify a goal to increase primary care spending by 1 percentage point per year. This goal is a bit more granular than the existing 12% goal, and as it introduces additional touch points for accountability. Cost board could also recommend that the legislature require agencies to publicly report primary care expenditure ratios of all carriers, so HCA, the Benefit Exchange, and OIC, and that would contribute to some of that more public monitoring. Some additional next steps for HCA, we could ask carriers to provide plans for how they intend to shift their expenditure ratio incrementally in the coming years during their annual expenditure reporting, and that would be most similar to how Oregon asks for plans and would allow us to get a bit more information. HCA could convene an annual advisory committee on primary care review, and HCA could consult with partner states to learn from their ongoing activities. So with that, I'll stop talking. Kaylee and Judy, if you have anything that you would like to add, please feel free, and otherwise we welcome discussion from the committee.
Well, I think we can start off with the great conversation that was in the chat. Jenny, thanks for that initial question about how that authority in Rhode Island came about. It was a legislative statute, and thanks to, I'm not sure who dropped in the chat some of that background info, that great Health Affairs article. But yeah, it was the legislature in Rhode Island that gave the Insurance Commissioner's Office that authority for hospital rate review negotiations, as well as the look at, primary care, and I think also behavioral health spend for statewide accountability. So yeah, a direct legislative mandate for those activities.
Thank you.
Any other questions or comments?
I don't see any other hands raised at this time, Kaylee. Oh, I see one now. Ginny?
It's me again. I was just curious if it's within the sort of scope of control of this group to recommend legislation. I mean, could that be something that this body does, or would it be to recommend to others something like what was, not saying that the Rhode Island solution is what should happen, but as we think about the realm of possibilities and that everything is sort of changeable in policy, could this be a solution?
Great question. Mandy, could I, or Judy, could you speak a little bit to where recommendations from this body go?
Yes, I will speak to that. So recommendations we make go to the full cost board and get put in a legislative report that is ideally an ask for things to happen. And so, yes, absolutely, we can recommend that we want that to happen. I will say in Rhode Island, they have a specific health insurance commissioner. Ours is just an insurance commissioner. So they do all kinds of insurance, health and otherwise. But this is certainly something that we could recommend happens. Yes.
I see Mandy's hand raised. Thank you, Judy.
Mandy, do you still want to talk?
Yeah, I just realized you have to unmute in two places.
Yes.
So I understand, we're kind of talking about like some of the recommendations. Would it be fair for us to talk about like, okay, so could we talk about, we're talking kind of, I guess we're kind of leaning towards carrots. Can we also talk about sticks as well?
Absolutely.
Because we don't have anything on here. So it's almost like one way to incentivize certain groups to do certain things is because the consequences are severe enough.
Yes. And I'll also say that I don't see anyone from OIC on, but we have been in conversations with OIC about how they could add this information now without legislation to the rate review reports. So they can ask for it with sort of the caveat that, as you mentioned, Mandy, there isn't a stick attached to that. There's not a requirement. So I think that could be a space that we could talk about if you guys want to.
I see Sean has his hand up.
Yeah. Well, I feel like there's an elephant in the room, and I'm just going to say it because I don't know, because it's important. But I think everybody participating in this group has really good intent. I have no doubt about that. But unless there's some kind of teeth, asking for a goal, I'll just say is like pouring a glass of water in the ocean to raise the tide. So unless there's some kind of teeth and meat and accountability to this, I don't think we're ever going to get anywhere except continue to spin our wheels until it's too late. So that's just my input.
Yes, I think that's helpful. And if you guys want to change something about the recommendations for this, or to put in penalties or something like that, we can for sure do that. If yes.
It looks like Sharon has her hand up.
I do. I may not be able to translate this completely correctly because I'm chatting back and forth with Drew Oliveira, and he says, regulate hospital rates to break even with 10% with incentives for more than increase the conversion factor for primary care providers, and then prepay for non-direct patient care work and move to full PCP cap and specialist bundles. So basically kind of trying to, I think, say where the money could come from, because we have some evidence, I think, in multiple reports now that hospitals are kind of being overpaid. Not that they agree with that.
Tony?
Yeah, I'm not sure how we go about doing this. This is a super important point, and Sean, I really appreciate you bringing this up. I think the accountability fact, we absolutely have to. I'll put my video on. I think we really have to build in. I just don't know if we're going to do this as a sidebar conversation with all the other stuff we have on our agenda here. I wonder if we want to like maybe have a subgroup look at this and come back with some recommendations, folks who know policy and stuff. I think controlling costs at the hospital level, as Drew is suggesting, is a good idea, but that's a little different than incentivizing the 1% and how we can get some teeth into it. So I don't want to lose this conversation. I just don't think we're going to have a time to wrap it up today. So I'd look for others to see how we might incorporate some recommendations at the next meeting, perhaps.
Yes, we can definitely, during the interim, so to speak, today we will have gone through, after today, we will have gone through all 7 recommendations. And so you're going to have some homework about whether you want to add anything, change anything, you know, sort of reword things, that sort of thing, so that we can talk about them at our June meeting and prioritize things. So Mandy, I don't know, I'm looking at you in the conference room. I don't know if there's any rules around, we are an open public meeting, if there are rules around if members want to get together and talk about things, or how that works, or just have people submit things to us and then we summarize at the next meeting. I don't know exactly.
We're gonna have people get together outside of an open public meeting. And they can't exchange emails together as a group, but they are welcome to email us directly.
Okay, great.
Because that triggers an open public meeting when let's say when members respond to a group message, let's say. Does that answer your questions, Judy?
Yes.
Okay, great. And I see Tony has his hand raised. Were you, Tony, were you able to answer? Okay, you just lowered it. Thank you.
I just want to flag that we did also include some time for discussion after we've gone through all of the presentations. So if we want to continue the conversation within the context of all of those, I know that that's slated at the end. So no intention to cut off a good thing, but just wanted to flag that that's also in the itinerary.
Excellent. Yes. Kaylee, do you want to carry on then?
Sounds good. Yep. All right. So the next strategy that we're going to talk about is this one that I mentioned is probably the most straightforward and targeted one to really take a look at Medicaid reimbursement, which HCA has more direct sway over, obviously, with legislative direction and budgeting. So I think this group has talked multiple times about roughly how to benchmark Medicaid payment rates relative to Medicare, making Medicare kind of a standard benchmark at which we can all reasonably compare across different payer types. And of course, as you all know, reimbursement can vary pretty dramatically between those different payment types for the same type of service. So the latest numbers that we have available go back to 2019, where we compared the fee schedule rates for covered services relative to that same covered service on the Medicare fee schedule. So this is not weighted by utilization of those different services. So it can range, right? But, somewhere between 50 and there are some services that are well over 100% of the Medicare fee schedule. But on average, it's around 70%, somewhere between 65 and 70% is our best estimate for what the Medicaid fee schedules are currently reimbursing for primary care services. So the hypothesis for this Medicaid rate increase and how it would contribute to increasing our total spend on primary care goes back to that basic, price times utilization equation that we talked about in the beginning. Presumably higher Medicaid rates would encourage more providers to accept Medicaid patients and provide services to Medicaid enrollees. Which could create better access and more utilization. So you would be driving up both the price component and the utilization component to increase overall primary care spending. So we did want to take a look at the experience from other states on this. As of 2019, that same comparison point that I just shared with you, where we're, probably somewhere in the 65 to 70% range for our primary care prices as a percent of Medicare. There were about 12 states that had primary care rates at or above 90% of Medicare, and only 4 states that were at or above 100% of Medicare for their Medicaid fee schedules for primary care. I do want to note an important piece of context that CMS has been requiring states to really take a look at this benchmark of their fee schedules relative to Medicare for primary care, as well as a couple of other core essential service categories. And in the context of 1115 waivers, which are the waivers that allow us to play with the services that we cover to try to expand those into, for example, health-related social needs. So CMS is requiring that states be at a certain benchmark level as a condition of approval. And so Washington, like many other states, have been steadily implementing increases in our primary care payment rates for Medicaid over the past few years. In fact, there is another planned increase that will go into effect July 1. That's in the works with our team now. So that said, there is some mixed evidence from literature about the relationship between primary care payment rates and that provider participation. So the willingness to accept Medicaid enrollees and provide services. So on the one hand, there is evidence of a strong relationship. We've seen in some literature physicians in states that pay above the average Medicaid to Medicare fee ratio tend to do better. You can see a noticeable increase in participation rates depending on how close or above a state is to that median fee-for-service payment ratio. That said, there is kind of a rather infamous example many of you might be familiar with back in 2014 and 2015 under the Affordable Care Act. There was this temporary fee bump in place for certain primary care services in Medicaid. And there have been a number of studies that show that that temporary bump didn't necessarily produce a sudden change in access to care for Medicaid enrollees. That said, there have also been some great nuanced assessments of how implementation of that temporary fee bump had some major hiccups. There were delays in implementation, and providers obviously knew that the duration of that fee bump was temporary, and so didn't necessarily change their practice behavior or their panel of patients for that temporary time. So really some mixed evidence about the effectiveness of those primary care payment rates. And we also wanted to note, given that really nuanced assessment of this relationship between payment rates and provider participation, there are a number of other factors that providers have to take into account: administrative burden, the referral pathways, and the ability to, have specialty care providers that are available to accept patients as needed, providers' perception of Medicaid as a chronic or persistently low payer, and the mix of patients in a given service area. So a lot of mitigating factors there that I think some of the better studies that we've cited here really take into account. We did want to really emphasize the inequitable payment distribution and how that can impact racial disparities in outcomes and access to care. There are a lot of great studies that show that those disparities in outcomes and that people of color are overrepresented in the Medicaid population, and we are sensitive to the lower Medicaid reimbursement and how that disadvantages populations that are disproportionately represented in Medicaid. So multiple reasons that we want to think about what that Medicaid reimbursement change could do. We do want to be conscious of the provider burden, that administrative burden that I just mentioned for providers to work with the Medicaid program. As of right now, we have multiple billing guides that providers have to be familiar with and know which to bill under and what their reimbursement structure would be. Like I mentioned, CMS has required some rate increases for certain types of services, but not other types of services. The legislature will try to target payment rate increases to certain services to be fiscally conscious, but that creates, we took a snapshot here of the myriad fee schedules that exist, and this is just the physician and professional service fee schedules and billing guides that exist. So we are trying to be conscious as we think about this Medicaid primary care rate increase. We don't want to create yet another primary care fee schedule. If we can really use these existing fee schedules to target that increase and achieve this policy aim of mitigating the disparities in the payment rates between Medicaid and Medicare. So back to our primary directive for this group would higher primary care reimbursement increase the primary care spending ratio. So thinking about that numerator denominator dynamic again, there is clear evidence that better access to primary care, which presumably could come with higher payment rates, can prevent the need for expensive and acute care. So we would be spending more in the numerator and hopefully driving down costs in the denominator, which would increase the ratio. So there's a chance of that. However, there's also really robust evidence that increasing access to primary care could also and does also increase access and the use of specialty and acute care, and that is clinically appropriate. You're identifying patient needs that were not previously identified. However, that does mean you're driving spending up both in the numerator and the denominator, which doesn't change the ratio. So it really is the context, the content, the way that we try to drive that primary care spend increase can have an impact on the overall spend ratio. It matters the way that we go about trying to do this. So, excuse me, going back to that logic model again, evidence does suggest that there's a connection between higher reimbursement and better access. There is certainly a connection between higher reimbursement and an increased ratio of primary care expenditures. We think that that is a reasonable assumption that we could get to. Of course, that risk of driving up costs in the denominator is also real, but if you can do that in outpatient or to preventive specialty care rather than acute care, again, it matters the way that it's done. And we also talked about some positive effects on reducing health disparities, increasing health equity, and hopefully creating some stability in the workforce. So in summation, we think there's solid evidence that increasing Medicaid reimbursement can increase access and utilization. It might have some mixed effects on that overall spend ratio. And we do think, like we talked about, this is one of the more targeted, direct approaches we can take to have an impact on this approach. So our recommendation here is really, HCA is already considering this work. We are already pursuing it actively. We'd love to have this body show some support for that work and for you all to continue to monitor this Medicaid, Medicare spend ratio. We also want to be very transparent that we really are trying to minimize provider burden in this process. Think about how to use existing fee schedules to not create more burden or confusion about those multiple fee schedules. So that is all work that's underway and that we would keep you all updated on regularly. I think that's it for this one. I want to pause here. Judy, do you have any other comments you want to add here before we open it up for questions and discussion?
No, I think that was a really nice summary. And yeah, I think all of these recommendations today very nicely fit together. So yeah, let's see if people have comments or questions about this one, and then we'll do number 6 and then have a big discussion about everything. Sean, you came off I don't know. I was going to say mute, but it's not mute. I can see you. Your camera turned on. Do you have anything you want to say, or I'll go to the raised hands?
Actually, I felt like I am not up to date on how Washington Medicaid rates for primary care stack up against national benchmarks. If you could remind us.
Yeah. So right now we think we're about 70%. We're running this analysis again for a couple of reasons. One, because there have been recent increases that have gone into effect, and there's another one coming in July. So we're running this again. And two, we think it's important to separate out the price comparison, just comparing fee schedule to fee schedule, and taking into account utilization mix. Because there is such variation, we have pediatric providers and certain services that are up much higher than other services. So we're going to bring back an assessment that takes into account that utilization mix. But the most recent data we have is that we're probably somewhere around 70% of the Medicare benchmark.
And what percentage of Medicare is
70%? Yeah.
Of Medicare, and okay. And then compared to Medicaid in other states, also 70?
That compared to Medicaid in other states, I don't have that offhand. We can look into that for you.
Thank you.
Crystal?
Thank you. I just have a little bit of a caution or comment on, I think it's a fair call out that if we get these patients into primary care and we identify some needs that haven't been addressed, the cost will go up. I think that's probable in certain areas like specialty. So just a caution that when we are measuring that, when we're looking at those costs, we really have to give this time, right? That's maybe my caution is all of this is just going to take time. And so making sure when we are doing these policies, having and discussions, that we're really clear with the legislation too, that this is going to take time. It can't be a short-term process.
Yes, totally agree. Maddie?
So I'm one of the nurse practitioner ARNP representatives on this committee, and Medicaid currently reimburses physicians, ARNPs, PAs, all the same rate. But Medicare reimburses nurse practitioners and PAs at 85%. So how is that going to be? Is that going to impact this, or are we just going to stick with one fee schedule for Medicare?
Great question. Yeah, really, really good question. So we are, I think it's tricky for us to have this recommendation be this simplified of go to parity with Medicare, because one of the reasons you just identified, the NP differential in Medicare, which we as a state do not do that and would continue to not do that. There are also services in the state of Washington that are paid above the Medicare benchmark, and we would not decrease them to be at Medicare parity. So I think we need to be a little more precise in our language here, including the NP differential call out. Really appreciate that feedback.
Great, thank you.
Tony?
Yeah, I was also just going to say there's a political element to this as well. We enjoy the support of WISMA and specialists for the most part in terms of primary care spend. But I think good patient care, honestly, you would see an increase in primary care spending through Medicaid, but probably in other specialty services as well, at least to some degree. And I think we should be a little cautious in making this an emphasis of primary care spend through a Medicaid rate increase. So again, I think that should happen for good patient care, and I'm all for it, but I think it might be better off as an across the board or bringing, equivalent primary care with others at a higher rate, but not making it the focus of a primary care spends. Just a thought.
Great, thanks. David?
Yeah, Kaylee and you, I'm just thinking through how broadly we have to think about this. To me, this seems like a no-brainer in terms of the most direct method to achieve the objective or contribute to achieving the objective. There are bigger issues like, is the legislature prepared to fund this, or would this require a trade-off with, not funding something else in education or something like that? And I'm also thinking about supply. Like, I think we have understood that there's an undersupply of primary care physicians. And so if money is being added to the pot, is there supply to be able to respond to that and increase services? So I'm just wondering what you think about how those broader issues fit into this.
Yeah, really appreciate that, David. I think that is why it's wise that this committee is considering those 7 strategies as a package. Workforce is one of those, because we know, like you said, there is a supply issue there. I think there's also probably arguments that we can make about dwindling supply because prices are chronically low. And that if we are making those investments in a persistent price increase, can that show workforce that there's a future there, that it's a desirable pathway to practice medicine? So yeah, there's a lot of nuance and interactions to play here. On the budget note, you're right. This is going to probably have a hefty price tag associated with it. We have not conducted that analysis quite yet because we're still figuring out what those increases are going to be effective July 1. So we'll do that after we have those new fees put into place. But yeah, it will likely have a big price tag attached, which is why as of right now, the recommendations that we as a staff are suggesting to you all is for HCA to continue that work and to assess what that price tag is before we recommend fully to the legislature. We just want you all to know what that price tag is as you make your considerations. But Judy, I want to give you a chance to answer all that too.
Yes, no, I mean, I was going to say all of this is complicated. If we knew exactly how to get to 12% or how to magically make primary care be able to do all the things we want it to do and be fully staffed, like, we would not need to have all of these conversations. And so I think, and I'll talk about this at the end, but I think in terms of time, like, none of this is going to happen fast, and none of this is going to have a really big impact quickly. So figuring out how to make the sort of stepwise approach of where do we start in these 7 recommendations is going to be the focus of our next call, to try and sort that out. So yes, I think that's all I have to say about that. Tony, did you have something else to add? No. Okay. I think let's move on to Karen's presentation, and then we'll keep talking.
Yeah, thank you, Judy, and hello, everybody. It's a little surreal to be back here with so many of my former colleagues and members of the Washington Health Alliance, and just a real delight to contribute in some small way, I hope, to the ongoing work that continues in the state that is just so impressive. So Judy, as she said, I was going to talk, well, she gave me, when I was invited to this, I heard 2 tasks. I heard one, to just talk about why it's important to incentivize and measure non-fee-for-service payment, and also point to some of the work that's happening in other states. So my formal presentation is much more focused. Oh, you can leave those slides up, Rochelle, or whoever's sharing those.
Just taking over.
Oh, okay, fantastic. Thank you. And so focus mostly on the formal presentation, which is only 10 to 12 minutes, hopefully, is focused on sort of why we think this is important, which I'm sort of preaching to the choir, but this goes in a public record. And so good to have, I think, some of this documented formally for you. But also I'll talk a little bit about what states are doing, and you can go to the next slide. So the specific things, I'm just going to start with the basics, which we can do a really quick flyover on for this group, about why fee-for-service doesn't serve primary care well, and why well-designed primary care payment should include both fee-for-service and non-fee-for-service payments. And if we're going to try to grow it, let's try to grow the kind of payment we really want more of, not the stuff that we know is not working as well. I'm going to talk about the LAN, the healthcare payment Learning and Action Network, APM, alternative payment model, how many alphabet soups can you get in there, framework, and sort of the measurement approach that they've taken to that, something probably familiar to most of you, but maybe not all of you. And then just talk about how incentivizing and measuring non-fee-for-service payment things contributes to your state goals for primary care. And I changed my mind here. I was going to list it all out, and I decided to make it a teaser. So a little quality control on the slides there. So the first thing that we're going to cover is just the fee-for-service basics and why APM. So you can go to the next slide. There we go. We know this. We know the payments are undervalued. We know that it's burdensome to document, particularly for primary care. And it's because fee-for-service is really designed well for discrete services. And that is not consistent with the comprehensive and continuous nature of primary care, as you all know. You can go to the next slide. Of course, the National Academies gave us a great cookbook for doing the right kind of, or a better design for primary care payment to pay for primary care teams to care for people, not doctors, to deliver services, when they published their report on implementing high quality primary care in 2021. This is objective 1. And they essentially call for a hybrid payment model, which retains some fee-for-service for those services that are not necessarily core primary care services, but often done in primary care settings, or those that we really want to continue to incentivize, in particular, such as immunization and other preventive services. Go to the next slide. So the Academy, the American Academy of Family Physicians, where I am today, and working on practice and payment policy, we have pretty well established policy on what we think well-designed primary care payment looks like. And these are the 6 principles that are contained in that policy. And it starts with paying prospectively to support team-based care. So we believe strongly that that needs to be prospective population-based payments, or per member per month, or capitation, pick the word that you prefer to describe this. And we think that's important for a lot of reasons. One of the things that it does is that it reduces the burden and gets away from the discrete service payment, but it is also a mechanism for really more actively engaging patients in the accountable relationship. In order to pay a prospective payment, you have to know who that physician is. And I know that we've spent a lot of time digging in claims to figure out who to attribute, which patient to attribute to which physician or other clinician. In reality, it would be great if we asked the patients. So we'll talk a little bit more about that as we talk about some of the land resources. And then the rest you see there. I don't need to read all of these to you, but I think it's just to underscore the importance of well-designed primary care payment has to include some form of prospective payment from our point of view. Next slide. So in reality, I don't think we know how much that should be. So if we're going to advocate for a hybrid payment model, how much should be fee for service? How much should be non-fee for service, and what's the right mix there? I don't know that we know the answer to that because we don't have enough of it in practice to really study other than through an HMO model, which is different because you do have a level of patient engagement and accountability and constraint in that model that you don't have in most of the insurance coverage that we're talking about today. So this chart, this graph is a representation of a simulation that was done by some primary care researchers, probably well known to many of you. And what they were looking at is what level of mix of the revenue would we need to get to that is capitation or non-fee for service to really shift primary care and sufficiently fund and resource primary care practices to move toward a proactive team and non-visit based care, knowing that the visit or the encounter is sort of the central value proposition in fee for service. And we know so much of primary care happens outside of that. So they said 63% in their micro simulation. This study was done in 2017. And it's a number that I think a lot of folks tend to use in practice. Next slide, please. So I'm going to move on and talk a little bit about the land framework and the measurement approach. Now, I put these in here just to keep me on track. So next slide, please. So hopefully most of you are aware of the Healthcare Payment Learning and Action Network. It was brought about or created through the Affordable Care Act. And the vision of this, the creation of this, was to really advance multi-stakeholder payment reforms to enable coordinated healthcare that achieves better health, equity, and affordability. And oh, by the way, Dr. Judy Zerzenthal is the co-chair currently, or one of the co-chairs of the HCP LAN. And they say they do these 5 things. Particular attention I'm going to pay over the next couple slides here is on what the work that they have done to standardize and measure this movement toward value-based or a different kind of payment for healthcare in general, but particularly for primary care. Next slide. So this is the framework. So they said, if we're going to be tasked with moving this forward, we got to have a way of measuring it. And so they came up with the categories 1, 2, 3, and 4, with category 1 being just straight fee for service, no link to quality or value. Category 2 being fee for service with some link to quality or value. Think of this as pay for performance, and even pay for reporting would probably fall into this category, some of the early versions of value-based payment. Category 3 would be APMs built on a fee for service architecture, which if I have a beef with the APM framework from the LAN, it's probably this wording, and you'll see why in a minute, because most of this is still built on a fee for service architecture. But this is really get into shared savings models, so ACOs and others that really work with upside and downside risk to create incentives for change. And then category 4 is really the population-based payments. So whether it's condition-specific or population-specific or more comprehensive in nature, it's those non-fee-for-service payments that are really saying you are, as someone who delivers care to patients, accountable for these services and or outcomes for these specific conditions. In the case of primary care, it would fit in that B category, that 4B category, which would really be much more comprehensive and global in nature. Next slide. So again, this crew knows that payment incentives matter, but sometimes it's complicated. And then we talk a lot, we use the language like we're going to move from fee for service to value-based payment like they're 2 distinctly different things. And we're going to change the incentives from, the one patient at a time orientation, which is all about filling appointments and maximizing limited time with patients, to a value-based care accountable patient approach, which is really about preventing disease and coordinating care and managing referrals and doing all those other great things that we believe can be derived from a more accountable value-based care environment. Next slide, please. So the reality is it looks a lot more like this, like value-based payment is layered on top of fee-for-service, and you're kind of doing it all. And that's where we go back to sort of the land when we're thinking about sorting out, trying to understand what's actually happening as payment changes, what form that's taking and how that's moving from the left-hand side of the slide, which is, you know, straight fee for service, towards something, particularly for primary care, around population-based payment. You know, we think that is really important to understand that. For all the reasons that we talked about at the beginning of this. Next slide, please. So just a little bit about how the land does this so that you can kind of understand and think about what would this potentially look like if you were to do this at a state level. And there are some states doing this, and I will talk a little bit about that at the end here. But they basically are collecting information through a survey instrument with payers, and they have pretty good uptake. They have a pretty strong participation from most payers who are submitting data. And they use third parties to do this, to collect the data. The data is not identified at the plan level, probably one of the reasons why they're getting pretty good participation in this. And it's shared through a data collection tool, and it's all very standardized. And then that's aggregated by the LAN, and they publish an annual report each year using those data that they collect through this mechanism. Next slide, please. And so this is something we look at when we're kind of trying to track and understand what might be happening here. And this is just the 7 years of, going back to 2015, the data that's been published on this. And you'll see that we've put a little down at the bottom on that little trend line, that's category 4, because that's the category that we are tracking closely. At the AFP, as we think about making primary care payment better. And in fact, recently I guess it was maybe over a year ago now, the LAN asked for public comment on some of the things that they were doing. And we've been in formal comments and sort of chirping in Judy's ear a little bit too about how important it would be for the LAN to start thinking about measuring how much of this shift in payment is happening in primary care versus other specialties. For all the reasons everybody seems to agree on how important it is to sort of reform the payment for primary care. Next slide, please. So in general, what do we see when we look at this? It's interesting, you know, about 40% of this has come as sort of stock fee for service only. That's probably a lot of Medicare payments, traditional Medicare payments. About 50% are those APMs built on some kind of fee for service foundation. That's really categories 2 and 3. And then about 10% is non-fee for service. And the question is, how much of that non-fee for service is going to primary care? If 10% overall is the number that is sort of non-fee for service, we have to believe a large chunk of that is actually going to primary care. And so what does that actually look like? And what could that tell us about how to sort of drive change further beyond where we are today? Next slide. So the last thing I'm going to talk about is just how important this is. I'm cognizant that this body is tasked with an incredibly difficult charge, which is to sort of prioritize these policy recommendations. I saw Sean's comment in the chat that, you know, we can do more than one thing at a time. It's just thinking about how do you knit together those things that you do, more than one, that sort of sum up to be maybe greater than the sum of the individual parts, that I think is really important. So next slide. I think, again, I think this crew probably knows this, but these are some of the things that we think about and talk about a lot as it relates to increasing investment through non-fee for service payments. It really can strengthen the accountability and engagement between patients and PCPs, especially if we lean into the recommendations that have been made by many, including the LAN, that when you start sort of tying patients to doctors for accountability, you ask first. And whether they're a member of a health plan or they're paid, let's ask, where do you want to get your primary care? And that's important for accurately directing payments. It's important for accurate measurement and evaluation. It's also important for active engagements of patients in that care relationship. We want to increase more flexible revenue streams that really give practices the ability to invest in people and infrastructure, whether that's technology or increasingly community partnerships to address social needs. How do we give them the most flexibility, maximum resources, most flexibility, and limited burden associated with achieving those payments? And that's the last thing that we're really interested in here. And we think that's so critically important for all the reasons that this group again knows well, but really improving the workforce is one of those factors that we think can have a dramatic impact. And we have many, many stories of family physicians who are in practices who are really benefiting from well-designed and well-implemented primary care payment that includes a substantial amount of non-fee-for-service payment. And they describe it as game changer. Next slide, please. So I include this slide, and I'm so glad that I did. I wasn't sure if it would fit or not, but I want to go back to the accountability conversation, because I think that this is out of the CPC Plus evaluation. So out of that 300-page report, this is a figure that comes from that. But I think it tells a really interesting story. So this is giving you the percentage of patients served by CPC Plus practices for which CMS or a payer partner is providing alternatives to fee-for-service, so a non-fee-for-service payment. So I'm going to focus on track 2 because that's where CMS provided the most substantial non-fee-for-service payments, as you can see in this chart. So before CPC Plus, overall, the total was 3%, and that was coming from payer partners. And you can see in the performance years of 1 through 4 that were included in this particular evaluation, that number jumps to 16%, 19%, 19%, 17%, driven almost exclusively by the CMS payments. So what it tells me when I look at this is that the payers increased their proportion of non-fee-for-service payments ever so slightly. And the other thing I think you need to keep in mind as it relates to this is an evaluation of the payer partners who voluntarily raised their hands and said, yes, we want to be part of CPC Plus. I was with one of those payers that voluntarily raised their hands and said, yes, we want to be part of CPC Plus. We already had a medical home payment model that included non-fee-for-service payments. And while those did increase over time, they did not change substantially. So this is basically evaluating the payers who are already doing what we want them to do, because those were the ones who joined in CPC Plus. What it's not showing you is all the payers who are still sitting on the side who probably are not doing much of anything relative to the non-fee-for-service payments, which is one of the reasons why they didn't join voluntarily in a program like CPC Plus, and now they have the opportunity in Making Care Primary. So that was a little bit of a soapbox. I apologize for that. I'll step off of it now. And the next slide, please. This last slide, I'll land it here in terms of the land, and then I'm going to talk just very briefly about some of the states. This is actually a snip, and these links are not live. But if a state like yours were to think about how to do this and how to align this with something like the LAM framework, all of the resources are public. There's a lot of detail here. And I think it's a very cooperative organization, and you know some people there who would probably be willing to help. So I think that's one of the reasons I included that there. And there's, Rochelle will make sure you get a live link to this page that includes all these resources. And so with that, I think you can probably take the slides down if you want to. And I was just going to talk a little bit about what's happening in some of the states. So the Academy's done a lot of work with states. We built a primary care investment toolkit for state chapters that is publicly available on our website, that includes a lot of resources and talks a little bit about non-fee-for-service measurement and investment. There are a number of states doing this. There's probably a short list of those that have sort of feel like they are figuring it out. Colorado, Delaware, Oregon, Massachusetts, and California are the 5 that are sort of top of mind for most who are following the space. And the other thing I would say is that California, in the last 6 to 8 months, published some information, and I'll put the link in the chat here in a minute, but they published a sort of a guidebook to mapping care primary care data types. So what's the non-fee-for-service category and how does it map to the LAN framework, which could be a very useful tool for a state like yours if you wanted to pursue this as one of the strategies that you recommend to the overall board for implementation. And with that, I am happy to take comments, questions. Say hello.
Thanks, Karen. I think I might pass it off to Kaylee to do the last bit because I think these two presentations fit together really well, and then we'll have some conversation about number 6. So Kaylee, do you want to do that? You are on mute.
Thank you. Yes, that is great. And Karen, you teed this up so perfectly. We're going to be able to skip through a bunch of the content that we had ready to present on this, including some of the basics of those value-based arrangements, that alternative payment model framework that the LAN talks about, and really think about this recommendation of tying the primary care spending to alternative payment models. So like we've talked about, it's not just that we want to increase the spending, the way that we increase the spending matters. It matters in helping to influence holding that denominator, the total spend, either static or, better directing that denominator spend to more appropriate care settings, more efficient distribution of spend. So with that, I'm going to skip through some of these. I do want to note with this LAN framework that Karen gave such a great overview, the Healthcare Authority really defines, or how we measure VBP adoption in the state of Washington is by these 2C and above arrangements. So including pay for performance, things built on that fee for service architecture to that, like Karen was talking about, that gold standard that we're really trying to get to for primary care, especially the population-based payments, moving away from a widget-oriented payment model. And we do some really robust measurement of VBP adoption in the state of Washington through a few different mechanisms. The primary one is our annual Paying for Value survey. We've done this going back to 2016, I believe, was the first year that this was implemented. I'm showing data here from 2019 on, just for ease of comparison and not putting too many bars on these on this chart here. On the left-hand side of your screen is HCA's Medicaid managed care population. On the right-hand side of your screen is our employee benefits population. And you can see here the change over time in the VBP adoption by category. And I should note that the non-VBP, the straight fee-for-service payment, are the orange bars up at the top. And then each segment increases in that LAN category as you go down the bars. So the green are that population-based, the level 4. The purple, the dark purple, are the 3B. The light purple are the 3A. So those shared savings, shared risk categories in the purple, and then the pay for performance here in the red. So as you will note, HCA, we've seen huge uptake over time in VBP adoption among our carriers. We incentivize our carriers to shift their arrangements in this direction. I do want to note, going back really even further back than what's on this chart, but to 2018, 2017, this green bar has stayed quite static in the state. And this, may not fully reflect just primary care service alone. I'm going to talk about that a little bit more in a couple of slides. But we've seen, pretty static engagement on payments being engaged in that population-based level over time. What we do see, and this is another section of our Paying for Value survey, is that most VBP contracting in Washington really is focused on primary care providers at this time. And so there might not be a lot of opportunity to expand VBP participation, but certainly there's opportunity to change the types of arrangements that primary care providers might be engaged in. So let me walk you through this image a little bit. So each of these circles, the size of the circle represents the number of plans that responded a given way. So we asked our carriers to describe to us for each of these provider types in their network, how much of their network was in some kind of a VBP arrangement. We didn't ask what type, just anything in that, pay for performance, shared savings, shared risk, or population-based payments. And as you can see, primary care providers just overall, our carriers were much more engaged with primary care and getting them into these types of arrangements relative to behavioral health, to perinatal providers, even to community health centers and rural health clinics where primary care is centered. But that primary care expansion of these opportunities has been more robust to date. So we will continue this paying for value survey using that land infrastructure that Karen talked about. We also, as you all know, do an annual primary care expenditure survey of our carriers. And we're going to ask them to start reporting that spend by APM category. We already asked them to report that spend for incentives, but we're going to continue that effort and continue to assess more opportunities for getting that level of detail through the primary care expenditures. Karen also previewed this really beautifully about some other leading states activities. She mentioned California, Oregon, Delaware. We also would just mention Massachusetts actually requires primary care providers and Medicaid ACOs to shift to that population-based model over time. They're also a Making Care Primary participant, so there's really nice alignment in goals and intent there. Our friends in Rhode Island also, as part of their mandatory increase in primary care spend, require that some of that increase really go through these alternative payment model mechanisms. So not only is there transparency in reporting, but they actually have that accountability that you all have been talking about as so important today. They have that minimum requirement that carriers are increasing that penetration in those types of population-based payment models over time. So we will continue to monitor this activity, the Paying for Value survey, the primary care expenditure survey that we do every year. We will continue to bring that data back to this group to show you how that's breaking down, and would love to hear your thoughts, your questions, and discussion about other potential accountability mechanisms in alignment with these alternative payment models. And I'm going to land on this summary slide here to bring together, I know we've been teasing this all along, but this is just a summary of all of the things that we've talked about today. These 3 different really robust strategies that you've been considering: increasing the primary care expenditure ratio by 1 percentage point annually, increasing Medicaid reimbursement, and considering if we should require that some of that spending increase has to be targeted towards alternative payment models.
Excellent. Thanks to you both. Should we have a little discussion about 6 and the APM models? Do people have questions? Cheryl?
Thank you, and get my hand down. I don't have question, but I think, I remember having this conversation, actually, I think, Karen, right before you were leaving us, actually, about how are we going to get there? And I remember saying, my biggest worry is this isn't going to be fast enough. It's not going to be big enough. And I still feel exactly that same way today. And so what I would say is that I would consider requiring Medicaid prospective payment or capitation by a certain date if you have a certain, and definitely there has to be nuance behind that of who you do, how many patients are we talking about or what percentage of your practice. But we have got to do something. Practices are closing their doors. We have lost 3 practices this year in our network. 1 completely closed their doors. 2 were bought out by big systems, which is not good really for patient care. We had several other practices since I've been here at 2016 who have completely closed their doors. Most of them are Medicaid, single, solo, small practices. I just feel like we need to do something and we need to do it now. And we need to be brave enough to do it. And I completely agree with Sean, and we need to put some really big teeth into it. Because nobody, my colleagues are not going to just do this voluntarily. I mean, they're just not. They're not going to say, oh, yes, I want to go first and please pick. It's just not going to happen. And I'm just really concerned for the health of our state and in particular the kids in our state.
Thanks, Cheryl. That is great. We've gotten very quiet. I don't know. Karen or Kaylee, do you have anything else you'd like to say?
Just how cool it is to be back in the room with all of you folks who are doing this great work in Washington State. I'm so glad to be where I am and doing what I am at the Academy, but really great to be with you. And I think the possibilities are endless, but I do think in order to make progress, you're going to have to be bold, to Cheryl's point. I mean, it's just not going to happen on its own. And so that's the part where it gets really tough and really uncomfortable. But, and you can be very creative in this space. And I would look closely at what, California is doing in this regard as well. At least the tools that they've created for you.
Great, thank you. Well, if there's nothing else, maybe we'll thank Kaylee and Karen for coming and appreciate your work on this and your slides. And I think it is super informative for the committee to think about this as we really start to hone down on our recommendations. So I wanted to take a moment about what to expect for the meeting schedule for the rest of the year. So as all of you know, our committee is tasked with providing advice related to the 12% primary care spending target for the Healthcare Cost Transparencies Board review. So we have a list of 7 policy recommendations that we decided we wanted to focus on. We've talked about each of them a bit more, and now the goal is to narrow this down to our top 2 to 3 selections to recommend to the cost board and to the legislature. And why we want to focus it on 2 or 3 is I think we can't do all 7 all at once. And I don't know, to Cheryl's point, something has to change. And I think some of the question is where do we start? And I think if we went to the legislature with 7 recommendations, it'd be unlikely that they would all be taken up. And so I want this to have impact. And so I think we need to sort of prioritize our list of 7 and give some real focus and hopefully some like pushing that will happen so that we can get to some action on this. So from the 2 or 3 top choices, I'm gonna share that with the cost board at the July meeting. And then they have everything they need from us to put together their legislative report for this year. So June is going to be our final meeting for 2024. And then we will come together again next year, both to review the primary care spend data, because we will have that, both in terms of claims and non-claims based spending. And we'll talk about what happened. Hopefully not if anything, but what happened in primary care. Sort of relook at our 7 policy recommendations, see if there's anything else we want to change, about what to do. Again, sort of do the same cycle, because the cost board has a legislative report every year of recommendations to the legislature. And so that'll sort of be the cycle from here on out. So are there questions from committee members about this? Any comments or thoughts? Here's our 7 so that you remember. And David?
Yeah, thanks, Judy. I'm trying to think through how we would get to 3 and assess the feasibility. And where my mind is going is that to wonder if there's a conceptual model or the opportunity to develop a conceptual model. What I mean by that is if we take, let's see, maybe number 6, for example, something's going to happen within that in order for us to get to the 12%. And I think that's going to take us to number 2, or that's going to take us to the ideas that Sharon was mentioning that Drew was chatting her about, which get into the way that hospital systems are paid. And so I'm wondering if it's worth someone's time to think through the chain of events of if some of these were in place, they by themselves wouldn't lead to the ultimate outcome. So what is it that would lead to the ultimate outcome?
Yes, that is a good question. And I don't know if we know that. And so I think that's some of the conversation we want to have. We have a few minutes this meeting, but I think the next meeting will be important too. I don't know, Gretchen, this starts to fold into sort of how we're going to do this at the next meeting. So maybe Gretchen, do you want to chat about the next steps and then we'll talk some more?
Sorry, I was muted. Thank you. That was a great transition. I hope you can you see me? Because it's funny, I actually can't see myself. So
no, you are not pinned. Maybe the folks in the room that are magical can unpin Kaylee and Karen and pin you.
And that's okay. You can hear my voice, which is
there you
it's
are.
a good thing. Okay, there we go. Hello. And let me move my screens. That is a great transition. And so if we can go to the next, just go to the next slide. Thank you. So HCA will send out that full list of primary care policies that you have been talking about. And you're going to have a little bit of homework. One is to respond to HCA with anything you have in terms of input of what you would like to see potentially changed about the policies, added on to the policies. So anything that would make them better articulated and sort of make it clear in terms of what next steps are or what you think next steps are. And then the other piece of the homework is to what Judy's just been saying, think about how you would prioritize this list of policies. I think the thought process that was just presented in terms of thinking of them as a package, that some may sort of be, sort of initial steps to a larger goal, that kind of thing. That is exactly how that is very strategic, and that is exactly how we would love to hear you thinking. And actually, in that response you do on June 7th, if you would like to incorporate some of your input on that kind of policy prioritization thought process, please do. Because I think the more input, the better at this point. And then we will sort of cull it down and bring it to the June meeting. And so then what we'll do, the center, myself, Shane, Amy, other folks that you've seen, will facilitate a conversation that gets you to finalizing the policies and then ranking them in preparation for the recommendations that Judy was just outlining. And just FYI, we'll probably be having you do a full ranking of the 7, just so for future reference, there is, sort of a complete kind of compilation rather than just doing, say, like the top 3, but then the idea with Judy is that what Judy was saying is that you move on the top policies. So definitely be thinking how you see them all working together and over time for that. And then we will see you in June. Anything else, Judy, that you would want to add to that?
You're on mute.
Oh, I'm on mute. No, that's great. Thank you. So Jonathan has his hand up. Do you want to talk a bit? I think answering questions about both of these things will be important. So you know your charge.
Yeah, I had a question. At first, I was going to talk about a possible amendment for us to consider to one of the policies, but it sounds like next meeting is going to be the time to do that. And so I definitely understand that the second step is going to be rank ordering the policies. And then in between now and next meeting, we're going to submit suggestions. Will there be a process during the next meeting by which each submitted suggestion is considered and then voted upon to be incorporated into a given policy before we then rank order the policy? I guess what will be the process for considering suggestions that are submitted for each individual policy between now and next meeting?
Do you want me to take that, Judy?
Sure. I can say what I think, but it may or may not be what you think. So we'll.
Oh, well, you can, we can, because this is an art, right? I mean, this is not there could be a science, but it's really sort of making sure everybody's input is heard. We would make sure that everybody's input is reflected in the conversation and finalizing the statements until we see the input. The actual strategy of how we do that may go maybe one particular process or another. Particularly because we may get several that could be merged into one change. And so you could see there being like, we've got 4 comments on XYZ. Is this a common change that could accommodate those, all of those suggestions, that kind of thing. So, so we would definitely, I think what the bottom line is that we wouldn't just dismiss a line of inquiry. We would figure out how we work that into the discussion in June. So Judy, do you have anything else you'd want to add to that? Or
that is super similar to what I was going to say. It sounds like there's some coalescence around like, where's the teeth for the 12% or what do we do? And so if we get like a number of comments, we can figure out like, how do we change that, or what does that look like? This is also your time. If there's something you feel like we totally missed, we could, now's your time to sort of add that as well. And I think if you have a couple of weeks, David, if any of you want to think about what your model is in terms of like what goes first and what goes second, next time will be a great chance to talk about that and sort of figure it out. So we don't have presentations planned per se for the next time. It's just really all discussion about how do we get to some action? How do we get to some piece of what this looks like? So.
Yeah, and I would just add, Judy, this, I think this, I think we've used it with this committee, and I know a number of you have been on other committees that we've worked on. For the actual ranking, we will be doing kind of a poll with ranking. So, you will actually yourself be going in and, ordering the options. So everybody will have that direct vote. But good question.
Thank you so much. That was very helpful. Yeah. And Judy, you read my mind with teeth behind the 12%. Also has a nice ring to it. So coming to an email inbox near you.
Excellent. Preferably sharp, pointy teeth, not the, although I don't know, maybe molars can just grind people down over time and get to somewhere different. But yes, I've been looking at dental, reports today, so teeth are on my mind.
If we really use that metaphor, I think we'd have to revisit our definition of primary care to include dental care.
I guess that's true. Do other people have questions or comments? Okay, then I'm gonna thank you all for participating in today's discussion, and the recording and summary of this meeting will be posted soon on our website. Our next meeting is Wednesday, June 26th. And we will be sending out some homework for you to start the wheels a churning, and look forward to comments that you might have. And I'm excited to get to an endpoint and get to some action where we can hopefully make some change. So thank you all very much and have a great day.
Thank you.
Thank you.